Professor Taura, thank you very much for your excellent technique. I think seeing your technique, I think you can persuade that they can be done very easily. Because there's no question, I will ask one question. So your Professor Gyoka has proposed another theory, Ranx theory. Yeah. But sometimes you don't follow the Ranx capsule. Sometimes you break the liver. So what do you think about the Ranx capsule theory by Professor Gyoka?
Yeah, of course, I'm very respectful of Professor Sugioka, but I have a feeling that, it's not something everybody can do, everybody should master. So that's what I'm saying. It's sometimes very, difficult to dissect between the Lennec and the Grisonian capsule. So I do not hesitate break the liver, break the Lennec capsule. That's what I'm saying.
Thank you very much. So we have another speaker, Salvatore, Dr. Gurta Dadburia, and also Professor Maurice is here, Professor Maurice, and also Professor Brian Go.
Yes, I'm here.
Yeah. Okay.
Yes.
So I think Professor Maurice is a colleague of Dr. Sugioka. So actually, Professor Taura has mentioned very important technique. So for Glisnian Petker approach, you don't have to see the Lannex. Professor Taura's main point is don't try to show the Lennec. Sometimes you can break the liver just to safely isolate the glycerin. So what do you think about that, Professor Maurice?
Yes, sometimes I do myself, I do the Professor Taura's method myself.
I'm very happy to hear that.
So segmentectomy and sectionectomy in that level, that is a very good technique, and especially for the residents and young surgeons. When I teach them, they are doing the operated, and I'm an instructor. In that case, they are doing segmentectomy and sectionectomy. In that case, that is a very effective method.
Yeah, thank you very much. And I'd like to ask Dr. Brian Go, Dr. Salvatore. So, Dr. Prosco, do you use the Grisonian Petker approach?
Yes, but I do not obsessively try to keep the Lennox capsule.
Yeah.
So it depends on the case, especially in cirrhosis. You may have some bleeding, and I would just break the liver.
Yes, Fresco. I have a same feeling because when they have demonstrate the Lannex, usually the liver is very normal. So I'm wondering if the patient has cirrhosis, they can do very precisely like this. So I think a cirrhotic patient to expose Lannex is not so easy. So, Dr. Salvatore, Gurtadauduria?
No, I don't use it. I don't use it.
You don't use it?
I do different technique. For major resection, formal, anatomic and intraparenchymal for minor resection, but not Glisonian approach.
Individualization technique.
Right.
Yeah. So, yes, I think that Professor Akawa is not here, but I know that Professor Akawa is a very active proponent for the Glisonian Petker approach, but it is Christian pedicle approach is very commonly used in the East Asia, like Korea, Japan, and maybe Singapore, Hong Kong. But in worldwide, I think Christian pedicle approach is not so well used. So I don't know. Anyway, for me, for anatomy dissection, Christian pedicle approach is very good. But for colorectal liver metastasis or other metastasis, you don't have to do anatomy section, I think. And I'd like to ask Dr. Taura. So you mean you have seen that for superficial tumor, so you have shown that for some example of the tumor in superficial lesion, you said that the anatomy section is right anterior sectionectomy. But many surgeons say that third branch or fourth branch Christian pedicle isolation, you can do very small anatomy section. How do you think about that, Professor Taura?
Yeah, the problem of my technique is isolating third or fourth branch. It's very difficult, and I have seen many elegant videos by Professor Wakabayashi, Professor Sugioka, but my feeling is that it's not something everybody should master. Maybe we can go through between the right and left parenchyma and try to find the the Grisonian pedicle for segment 8 from the cutting surface, which is very close to the intersectional plane between the right and left. So that's what we usually do for segment 8 resection in laparoscopic surgery.
Thank you very much. So I don't know who wrote this, but if I read it, we must know both technique, Lanek and section, depending on liver anatomy texture. So I agree. And also Christian Lanek paves a path right from beginning to guide precise dissection, preserving much of parenchyma. Yes, I agree. Yes, I agree with that. But for the Lanek is actually the capsule of liver parenchyma, and the Professor Sugioka's concept is we can separate Lanek from Gleason. So, but there's some risk that if you want to separate the Gleason from the liver capsule from Lanek, it has a possibility to injure the Gleason. So Professor Taura's method is that don't try to see the Lanek. Sometimes you can break. There's no harm. Then the safe isolation is better. So I think that we may have a debate here, but I think very strong advocate is Professor Wakabayashi. And also maybe Professor Sugioka. I agree with them, but there's some other ways to safely dissect it. So I think. So Dr. Salvatore, so how do you think about the anatomic and non-anatomic section in your practice? Salvatore, you please turn on your mic.
I have seen a beautiful video showed today by Master of Anatomical Liver Resection. We have a little bit different experience in my hospital and in I would say not all but many Western centers. It's especially when you consider liver resection for HCC, you consider a tumor that you can treat over time, several times, and you have available different techniques. So I think most majority of centers, they do like non-anatomical resection, and you may treat recurrence again through minimally invasive approach, and then you have the possibility, which is a real possibility, to transplant those patients when they recur. So especially in cirrhotic patients, we don't do many major anatomic or major right or left hepatectomy. We try to save parenchyma, but again, in my experience, I don't do many anatomic. I do much more wedge and much more different kind of resections.
Thank you, Professor Grattaduria. May I call you Professor
You can call me
Salvatore?
Salvo. You can call me
Salvo,
Salvo.
Salvo, yes, Salvo. Thank you very much.
Thank you very much.
Salvo, Salvo, so Salvo, thank you very much. Yes, I think that there's some debate of laparoscopic versus non-anatomic resection. Dr. Taura, Professor Taura didn't mention about which is better. So I'd like to ask Professor Taura later. So I'd like to ask Professor Morise about your thinking, your thought on the survival difference between the anatomic and non-anatomic. Professor Morise, how do you think about the debate?
Yeah, that's an important point. I think superficial small tumor, for the superficial small tumor, there is no, my feeling is there's no difference between anatomical and non-anatomical. But still, when we do a laparoscopic liver resection, we can do an anatomical way. We can do the get the good margin of the tumor, surgical margin from the tumor, because in the laparoscopic liver resection, there is a difficulty of ultrasonography, laparoscopic ultrasonography, and we can get touch sensation, and that kind of difficulty in laparoscopic liver resection. So in that aspect, I do small anatomical resection for surface small tumor, but I'm not doing that in oncological reason. So that depends on the situation, but partial resection is okay with good margin for small tumor, surface small tumor, I think.
Professor Morise, actually, I agree with you. So small superficial tumor, I think anatomic resection is too much. If the tumor is deeply located, it's difficult to do partial resection. Then we can do anatomic resection. But superficial lesion, anatomic resection is too much. I think oncologically, I don't know. But in technically, there's much bleeding. Operation time is longer. So small tumor, I prefer tumor-to-me. But we can make call this if we isolate the glycine caused the tumor, we can call it as an anatomy section. But as Professor Taura mentioned, if we do not call it anatomy section, it's a tumorectomy. I think tumorectomy may be enough for. I would like to ask Professor Brian Go, how do you think about your thought on the anatomic and non-anatomy section? So
I agree with both of you. So for superficial lesions, I will just do a simple wedge resection. And for deep lesions, it's actually easier to do an anatomical resection. So I will do an anatomical resection.
Thank you very much, Professor Brian Go. So because we are a little late, so I'd like to ask Professor Taura, because you didn't say your thought on the anatomic versus non-anatomic section. So would you please tell your thought on the anatomical and non-anatomic section, Professor Taura?
Yes. as you know, there's a couple of studies, retrospective studies that compare the anatomical resection, non-anatomical resection, and some showed superiority of the anatomic resection. That's what everybody knows. But I have a feeling that that is a product of selection bias, patient bias. That's my thought.
Yeah, Professor Taura, thank you very much. So yes, I had reported some article that remnant liver ischemia is more important factor than anatomic, non-anatomic. So if we operate, if there's a remnant liver ischemia after dissection, so patient prognosis is not good. So if you want to do, I think precise technique without leaving remnant liver ischemia is very good for the patient. So for me, I agree with you. Anatomy, non-anatomy may be not so important. So anyway, actually there are many attendants. I can see the Ella there from Turkey, and also I know iPhone. Yeah, you don't have your name, but I appreciate your comment on that. And there's many attendants. So if there's any question, you can ask any questions. Please turn on the video. You can ask question. So if not, so I'd like to close the session. I appreciate all the speakers for this webinar. I see Dr. Janice Morris and Dr. Brian Go and Salvatore Salva, and also many audience, and also Professor Kabayashi and the Professor Troy already left, but I appreciate them. And also I appreciate many also for contributing special edition of hepatoma research. So I think most of the people already viewed so many times, several hundred or so. This is a very important article already. So I appreciate hepatoma research, some person, including Victoria and also Delphine, and we will meet soon. I hope that everybody is well and healthy. See you later. Thank you very much.
Thank you.
Thank you.
Thank you very much. Thank you.
Thank
Bye-bye.
you. Bye-bye. Bye-bye.
Bye bye.